Can everyone hear me?
Yes.
Let me share my screen here. Okay, can you see the PowerPoint?
Yes, it's all good.
Okay. Always hard to see on my side, except from obviously my own screen. So, okay. All right, there's a lot of slides here. The intent of this talk is to put as much information that you might need on the slides, and so that I think you get a copy or a review. So we'll keep going. Since I'm last, I think I can get through them all. Okay. And then we might have time at the end because since I'm last for any questions. Okay, you don't need to know much about this except patients should go to the most appropriate trauma center. Can everyone hear me okay?
Yes.
Okay, and just that level 1, level 2 trauma centers had the same equivalent clinical um, uh, amount of services. So this is what you probably should know a little bit on pre-hospital. They have protocols to follow, scoop and run. You take the patient as quickly as you can. You don't waste a lot of time in the field. If an airway can be maintained by bag masks, they should not take the time to intubate. So, they shouldn't be criticized if the patient's not intubated if they are able to maintain oxygenation. They can decompress the chest in the field with no breath sound to hypotension. They are not supposed to hyperventilate brain injuries anymore. They shouldn't give too much fluid. If they can't get an IV, they should use an idle cath in the tibia or the humeral head. Tourniquets and direct pressure. Packing. This is all stop the bleed. You should know stop the bleed. It's all around, and for civilians even to do it, but that's the stop the bleeding is most important. They can give anesthetics. A lot of places give anesthetics for open fractures, and then they can also, a lot of ambulances also have TXA they can use for hemorrhaging patients in shock, and a lot of places also they can clear C-spine in the field with nexus criteria, which we'll go over later. Be careful with those tourniquets in the right place. You need to know the Glasgow Coma scale. There it is. You might get a question on this, where you have to figure it out, or at least know it and trying to answer the question. You probably don't need to know this, but just if you ever hear of it, 12 is perfect. Any score below 11 on a revised trauma score is important when they're coming in from the field because it usually means that they're unstable in some form or fashion. These are the trauma guidelines that AMS has. We won't go over them, but this is the kind of things that they follow to see which kind of trauma center they should go to. Again, trauma centers level 1 and 2 are equivalent with regard to clinical services. You need to know, obviously, your primary survey, CCDE. Secondary survey is a complete physical exam from head to toe. The adjuncts are the x-rays, your FAST, any other imaging. You might have to do emergency innovations. All of you, well, maybe you all haven't, but if you're going to a surgical field, we all have that. You've all taken ATLS, and so you know that you need to do the emergency innovations right between the primary and secondary survey. Resuscitate, mainly we'll talk about massive transfusion. Tertiary survey is done mainly to capture missed injuries. It's done within the first 24 hours of the patient being there. And you have to perform an alcohol-free intervention if the patient has trauma related to drinking. That is an ACS must, and that could be on the test. So airway, best way to see if they have a patent airway is talking. If they have any kind of stridor, it could be intrinsic. That means blood, something blocking the airway, blood, vomit, food, teeth. Extrinsic usually means a hematoma, which would be almost always a carotid injury, pushing on the airway, and then injury to the airway itself. They should be assisted with a bag. Definitive airway is a cuff tube in the trachea. This could be an endotracheal tube, nasal tracheal tube, or a tracheostomy. RSI is giving them a sedative. Succinylcholine plus minus. Rocuronium is used in some places, and cricoid pressure. If you can't put a cuff tube in the trachea, the LMA is the next airway to go to. We can put it blindly. You just have to pull the tongue forward and place it deep into the throat. Cricothyroidotomy is mostly done when an anesthesia can intubate the patient, but there's also some patients that are obviously won't be able to be intubated and need a cricothyroidotomy, which is in the cricoid membrane between the thyroid and cricoid cartilages. GCS less than 8, intubate. Be careful of ventilation injuries. Patient had burns to the face or certainly in the mouth, and they need to be transferred to a burn center. You should probably intubate them to make sure they're safe because it gets worse as time goes on with swelling. Patients in shock also might need to be intubated. Be careful in shock. I don't know if you'll get that, but the modern thing is the patient is in shock, but maintaining their mental status to an extent. And it's hemorrhagic shock, you probably want them up in the OR before you intubate them and they crash because of the loss of their sympathetic tone. There's a cricothyroidotomy between the thyroid and the cricoid cartilage. So breathing. So if you have no breath sounds in shock, then they get a chest tube. Now that might be a chest tube, it might be a finger thoracotomy. We'll go over that a little bit more. But they get some entry into their chest. You got to see, of course, it could be a tension pneumothorax. On ATLS, they have a scenario where someone has a tension pneumothorax, but you think they need to be intubated. If they have no breath sounds in shock, they're not intubated, then they should get the chest tube first. Be cautious that they might need a chest tube. They have subacute emphysema. If you have penetrating trauma and patients in shock, they obviously need a chest tube. If they are penetrating in the box, they might have cardiac tamponade, which you can diagnose with a FAST. A massive hemothorax definition is 1,500 cc's with ongoing bleeding, or greater than 300 cc's over 3 hours, for over 3 hours. Again, hemodynamic stability is the main thing. And thoracic emergencies, you can see some of them listed there. We'll go over a lot of these. The main answer to taking someone directly to the OR for any injuries is hemodynamic instability. That's the first answer. So any of these injuries that involve hemodynamic instability, they go to the OR. Okay, for circulation, check pulses. If you can feel radial pulse, usually blood pressure response to systolic blood pressure 80. You can see the other values there for femoral carotids and so on. You can check capillary refill. Not many people do, but just so you can see your circulation. Important for kids and older people. Hemorrhagic shock, those are the levels. And you don't really see hypotension. It's not obvious until you get level 3, which is almost a third of your blood volume. You really have to be suspicious if someone's tachycardic or tachycardic has a decreased pulse pressure, which usually means something like 130 over 110. So you look at that and say, oh, that's pretty good. But it's not, because the diastolic pressure is wrong. Patient says he's thirsty, you got to be very suspicious. There are 3 responses to resuscitation: someone who responds and stays responsive, someone who doesn't respond, and then there's a transient responder who gets better with the hemodynamic parameters and then gets worse again. Those people are kind of dangerous because they kind of lull you to sleep. Other causes of shock could be neurogenic, from spinal cord injury, obstructive tension pneumothorax, tamponade, or you could have post-resuscitation shock. The obstructive shock you have to rule out early. Obviously, it's part of your breathing part. Neurogenic is kind of exclusion. All those shocks can be treated with resuscitation. They'll all get a little better with resuscitation, but you also have to make sure you get the diagnosis. The shock index is there because I've seen it in some questions. If it's basically your heart rate or systolic blood pressure, it's pretty easy. If it's greater than 1, that's usually the simple way of saying that person's had a shock. Your access still needs a D2 large bore. IO would be the next choice, and the central line would be the third choice. Fluid is restricted mainly to 1 liter at the most. Your question might say minimal crystalloid. And if they're and any kind of level of hemorrhagic shock, you have to go for blood, possibly a massive transfusion protocol, which is 1 unit of blood to 1 unit of FFP to 1 or 10,000 platelets. Keep in mind that there's about 50 to 60,000 platelets in a pack of platelets, so it's 6 units of blood, 6 units of FFP, and a pack of platelets. Other things to do for stopping the bleeding, Reboa, which is a catheter placing a femoral artery into the aorta. Zone 3 is just above the pelvis, below the visceral vessel. Zone 1 is above all the visceral vessels in the chest. Zone 2 is somewhere in between. They don't really talk about that too much. If Zone 3 is preferable with regard to patient survival, but obviously if the patient is bleeding from one of their visceral vessels, you might have to go to Zone 1. Okay, 5 points of exploding heart. No, it's a hemorrhage. I guess that's from some movie. But anyway, these are what we talk about when looking at areas of significant hemorrhage. If someone's in hemorrhagic shock, you need in blunt trauma. Obviously, with penetrating trauma, it's more easy. But anyway, you want to look at the thorax. A chest X-ray should rule out a significant amount of blood in the chest. You want to look at the abdomen, which is for the fast. In the past, it was DPL. The only time I think there's only 2 residents in my program that may have done a DPL. Mainly probably in the ICU, looking for infection or something like that. But, basically it's the same as doing a lap chole if you do an open approach and where you're opening up the fascia and you check for blood instead of just putting that catheter in. And then pelvis, yeah, you get a pelvis x-ray. Any kind of major pelvis hemorrhage is going to be from a pelvis fracture. So all you need is a pelvis x-ray. I put CT scan there in small letters just to mean that someone who's hemodynamically unstable, you have to resist in your question going to the CAT scan. They have to be stable to go to the CAT scan. So long bone, you should be able to tell on physical exam. Obviously, your x-rays and external bleeding, it should be pretty obvious. Massive transfusion definition is 10 or more units of blood for 24 hours. The patients will have metabolic acidosis, hypothermia, risk of coagulopathy. Every trauma center has to have a massive transfusion protocol. This is ABC here is the assessment of blood consumption. That's relatively something someone else made up. Where your heart rate is greater than 120, your systemic blood pressure is less than 90. Positive fast for blunt trauma or penetrating trauma. If you have 2 or more of those, then you can start your massive transfusion protocol. There's all kinds of different things hospitals decide. Basically, if someone's in hemorrhagic shock and you're getting past your first or second unit of blood, which most places have in the trauma bay, you should do a massive transfusion protocol. Again, it's 1 to 1 to 1. We talked about the platelets. You give TXA 1 gram if the patient is arrived to you within 3 hours. After 3 hours, they have a higher incidence of VTE. You give the 2nd gram over 8 hours. That's probably going to change in the future where you just give 2 grams straight up. Makes it a lot faster, easier. But anyway, that's the protocol right now. If patients are on warfarin, they get PCC. And there's some efficacy with NOACs. There's also direct inhibitors with the NOACs that a lot of places don't have because they're so expensive. So they just use the PCC. The ATLS guidelines, if you have for emergency department thoracotomy, which is a left thoracotomy, if you have penetrating trauma and the patient has signs of life within 15 minutes coming to the hospital, especially if you suspect a cardiac injury, you can open up the chest. If they end up having a non-cardiac injury in the chest, their survival is much slower. If they have a cardiac injury, and some of the more famous trauma centers, they can have a survival up to 20%. Abdominal exsanguinating injuries, you have the same low survival. So really penetrating trauma to the abdomen. But if it's in the other abdomen, maybe it went to the heart, right? That's part of the box. Pediatric is the same for blunt trauma. You just don't do it unless they lose vital signs in front of you in the ED. You can do it because at that point, maybe you have a chance of cross-clamping the aorta. And actually, I think I have it on that. We'll talk about it a little bit later, except what you do. Disability is your central nervous system, your brain, and your spinal cord. You have to ask the patient you do a GCS, and you have to ask the patient to move all of his arms and legs because they might have a lumbar injury. Take off all the clothes, make sure you're looking at all the cracks and crevices, check under the collar. It's important, really important penetrating trauma because you want to know where the holes are early. So brain trauma, hyperventilation is bad. except if the patient is in the trauma bay, has an acute dilated pupil, and is on the way to CT. Then you can hyperventilate. Mannitol, unless the patient's hypotensive, in the trauma bay. Avoid hypotension with brain injury trauma. It increases their mortality by 400%. Hypoxia about 150%. No steroids for brain trauma. No steroids for brain trauma. Decompress the brain on the side of the dilated pupil if you don't have a CAT scan. If you have a dilated pupil, but a normal GCS, a person's not herniating because their GCS is normal. They probably have eye trauma. You can see a dilated pupil with uncal herniation on the side. You have to avoid hyponatremia. You have to avoid hyperglycemia. Don't correct hypernatremia too fast. You guys all know that. About 10 milliequivalents a day. It can cause central myelinolysis. You can have cerebral salt wasting or SIDH or DI with head injury. The first two are with a low sodium. The last one's with a high sodium. If the patient has SIDH, they're usually not hypovolemic, so you have to check their volume status. Cerebral salt wasting with hypovolemia. If they're not hypovolemic, one is salt restriction. If they are hypovolemic, it's sodium restriction, or salt replacement, I should say. And then the DI is a 300 rule. You have a systemic osmolality that's greater than 300 and urine osmolality that's less than 300. They have DI if it's a brain trauma patient. Usually, if patients get DI, it's a bad prognosis because that usually means that their hypothalamus is failing. Unless they have direct trauma to the pituitary gland with a fracture. So epidural hematoma, classic there. Patient has a brief loss of consciousness, then comes back, usually a minimal meningeal artery injury. There's all kinds of epidural hematomas in older folks that could be in different areas that don't expand as quickly as this one does. It can be lethal if the patient isn't seen in between to make the diagnosis. If you make the diagnosis early enough that the patient still has brain function, you can save their life. Acute subdural hematoma, of course, is underneath the dura. You can see it kind of falls along the brain there and spreads out. Has a worse prognosis because it usually means that they have a brain injury as opposed to just a fracture of their skull. If it's 1 centimeter guideline for operating, a big shift of a centimeter, survival in general is better in younger patients. Traumatic subarachnoid hemorrhage is in the periphery. If it's more central, you have to be careful. It's a ruptured aneurysm that happened first, and they should get a CTA. Lots of times neurosurgeons will get CTAs anyway now. If you have to monitor the ICP. So the indication for ICP monitor is a Vascular coma scale of 8 or less. And then also a ventriculostomy is better because you can drain the CSF. You can consider craniectomy and all these things if the patient has ICPs that are refractory above 20. Here's what a central subarachnoid hemorrhage looks like. It's highly suspicious for a vascular problem like a ruptured aneurysm. If you see something like this in that area of the brain, that's probably a medical bleed, a thalamic stroke. But it could be trauma maybe, but that's more highly suspicious in any case. The patient comes in as a trauma patient because they collapsed and hit their head. Obviously, you work them up until you can figure out what's going on. That's more common for frontal and temporal are more common for trauma patients, contusions. They get worse in 4 or 5 days of swelling, so they need to be observed closely right through that 4 or 5 day mark. They can get a lot of worse. They get herniation. Diffuse axonal injury is shaking of your head, and you pull your axons apart, and you have these little hemorrhages. It usually is they could have an ICP that's high or low. They need to monitor. Again, you need an ICP monitor if your Vascular coma scale is 8 or less in a brain injury. Prognosis is generally poor. The MK doctrine, which you might see, is pretty easy. You got 3 things in the head. You got blood. You got cerebral spinal fluid and brain mass. If the brain mass is getting bigger because of the injury, or maybe hematoma is occupying space, you can decrease the ICPs by decreasing the CSF, which a ventriculostomy can do, or you can decrease the brain itself, the area of edema. That's what hypertonic saline and mannitol is for. Hyperventilation used to decrease the ICP because it decreased the perfusions of the brain, the blood supply. That's why it's bad. Hyperventilation is bad. We did it for years and years and years, and we were killing brains because we decreased an organ that was injured's blood supply. So don't do hyperventilation. You can see the maneuvers there that you probably need to know. Cerebral perfusion pressure. You need to know, try and get over 60 is your mean arterial pressure minus your ICP. Those are the maneuvers: raise the head of bed, sedation, sometimes paralysis, mannitol hypertonic saline, and in an aggressive center, which we are, the neurosurgeon will do a decompressive craniectomy. Spinal cord injuries. Blunt trauma patients should have a collar and a spinal board unless they have the nexus criteria, which is they're alert, they have no pain, no deficits, no distracting injuries. A wrist is not distracting, but rib fractures hurt a lot. That's distracting. And no tenderness along the C-spine. Everyone else gets a CT. Plain films are no good. CT can rule out a serious C-spine injury. However, persistent pain or tenderness or deficits need an MRI also. If the patient's unconscious, sometimes neurosurgeons will clear him with just a CT alone. Sometimes they want an MRI. Incomplete cord injury warrants early stabilization. So neurosurgeons might not operate on a patient. They say, oh, the cord's injured, but if it's incomplete, they should operate on them, and you might see something on that. Consider blunt cervical vascular injury. We'll talk about a little later, which means you get a CTA. Any complete cord injury above C5 needs to have a tracheostomy at some point. They have injured their phrenic nerve, and they won't be able to get at the ventilator. They might come in looking pretty good. High index of suspicion to intubate them. Steroids are no longer indicated for spinal injuries. Penetrating injuries or fixed deficits, you don't necessarily need to stabilize them. And you avoid hypotension, so you keep them above 120 systolic or more. These are just typical fractures you might hear about all the time. Take type 1, 2, 3. The main unstable one for odontoid is type 2. A lot of older folks get that when they fall, they break their odontoid bone. Jefferson's fracture is when someone dives in a swimming pool, has an axial load, hit the top of their head, they blow out their C1. And then the hangman's fracture is a distraction injury with the fracture through elements of C2. Deezer chance fracture is through a 3-column fracture through the anterior column of the vertebral body, the posterior column, and then the posterior elements there. These are highly unstable fractures. It's like you took a buzzsaw with blunt trauma through your body and cut the spinal area. You didn't necessarily cut the spinal cord, but they obviously could have a cord problem if there's any kind of shift. So these need to be fixed and stabilized. Be careful when someone falls from a height. They can have compression fractures as well as calcaneal fractures. The Ford fractures to the maxilla involving the nasal complex and then a cranial facial disassociation. You can see the types of the Ford fractures you can have with 1, 2, and 3, and the percentages. All the Ford fractures should get a CTA of their neck vessels to rule out blunt injuries to the vessels. So you get orbital fractures, you have to check for entrapment, check for retroperitoneal orbital hematoma because you get visual loss. Obviously, you want to check the eye itself, make sure that there's no blood in the anterior chamber. Mandible fractures have a 3 times higher incidence of blunt cerebral vessel injury, so you need a CTA. CTA for all, you'll see the criteria in a second. So basal skull fracture, you get a nasal ear or ear canal, CSF, blood, battle signs, raccoon's eyes, no needs for antibiotics. Check facial nerve function. They'll actually decompress facial nerves early if they have a facial nerve deficit, as opposed to everything else, hearing and things like that, they'll work on later. But if you have a facial nerve, these are the criteria. You can see it's crazy. You don't have to memorize all this. I think look at the Memphis criteria, and basically if you have any cervical spine injury, if you have any serious head injury where A patient really can't, Glasgow Coma scale is low, soft tissue neck injury, you should get a CTA. Because they won't necessarily have signs of a stroke, but if they get signs of a stroke, it's too late. Have to have eye index suspicion. Many centers do pan scans, including a CTA of the neck. So they go right front, then they'll find like 20 to 30% of maybe grade 1 injuries, maybe grade 2s, just by doing that. I don't know what that means, but some centers do that. You can see the grades there. It obviously gets worse. The first two likely will only be treated with anticoagulation or aspirin. The other ones, except for occlusion, if it's occluded, they might not do anything. The 3 and 5 have to be fixed. That could be with a stent, or that could be open. Zone injuries, zone 1, the clavicle to the cricoid cartilage, cricoid to the mandible. Zone 2, mandible to the base of the angle of the jaw there, angle of the skull there is zone 3. It has to penetrate the platysma. They made sure the airway is secure, and then we'll talk about the management. And sometimes for esophageal injuries, you should do both an esophagram and a scope. Both of them are about 80%. If you put them together, you get above 90%. Check the patient out. If he's pretty reliable, awake and alert, and you do a swallow, and it's probably fine. Again, hemodynamic instability means the patient goes to the OR, doesn't matter where it is. If it's zone 1 and they're stable, you can see if it says symptomatic there, they might have those hematomas, airway compromise, so on and so forth. You do a CTA of the neck and chest when you do zone 1, because the injury could go down into the chest. Zone 2, if they're symptomatic, operative exploration. If it's zone 3, you do a CTA, not a necessary angio, and they can embolize. If they're asymptomatic, you should get a CT of the chest and neck again for zone 1. Some people explore asymptomatic, probably shouldn't do that. Some people observe them. If they're totally asymptomatic, you can just observe. More than likely, your place should get a CTA anyway. But you can observe injury, especially if they seem superficial and they're totally asymptomatic. Chest trauma is the second leading cause of traumatic death after brain trauma. If you have decreased breath sounds with shock, you need to decompress that side of the chest. You always be cautious if someone's intubated and it's the left, you don't hear breath sounds, make sure that the tracheal tube's not in the right main stem. The difference between tamponade and tension pneumothorax is breath sounds. So that question comes up a lot, especially in ATLS, trying to decide if a patient with a penetrating injury is tamponade tension. But breath sounds, tamponade will have breath sounds. Gunshot will likely need a CT. Your boxes, your nipples, throw notch to the costal margin. But you have to think out of the box. The studies have shown you can get cardiac injuries from any direction, so you have to think out of the box. Always look for a cardiac injury with your ultrasound, unless the patient's unstable and needs their chest opened anyway. Again, ED, the thoracotomies for 15 minutes for penetrating trauma. Ultrasound of the heart is early for penetrating trauma. You usually don't have tamponade with blunt trauma, but you could. A lot of those patients are dead anyway, so you don't necessarily see them. I know that there's a lot written about small chest tubes are fine. We certainly have had our issues with the retained hemothorax with small chest tubes, so I don't recommend it. But for trauma, especially if you have blood, if you just have air, then a small chest tube is fine. Rib fracture is the most common chest injury, the most common reason for bleeding and blunt trauma. Penetrating trauma would be the lung. Rib fractures can kill older people, so you have to be very cautious with them. You should have protocols for rib fractures with people over 65 or smokers over 55, where they get even admitted to a step-down unit and physical therapy, all this kind of stuff. That's a tension pneumothorax. It's a really bad one. You can also see, this is what subacute emphysema looks like. You can see that the diaphragm is pushed way down. If this patient is probably dead and this x-ray should not exist, tension pneumothorax is a clinical diagnosis. It's not an X-ray diagnosis. You have to make the diagnosis before you get an X-ray. It can anticipate with penetrating trauma. Sometimes people with penetrating trauma don't need a chest tube, but if they're decreased breath sounds and shock, and they should be in shock. A lot of times people who are really gun-ho might just do it for decreased breath sounds. If the patient's not in shock, awake and alert, then they probably don't need it. They probably get a chest X-ray. You always have to worry about a pneumothorax on the other side with a gunshot wound. You can decompress with a needle, but a lot of people do a finger thoracotomy now, which is in the fifth intercostal space where you put a chest tube in and just put your finger in if someone's in complete arrest. If you have a long enough needle that you can put in the second intercostal space on the midclavicular line, then you can do that. In the field, they use a pigtail catheter. This is a flail chest. You can see rib fractures in 2 spots and more. Lots of pulmonary contusion here. Always have a pulmonary contusion with a flail chest. That's where they lose their oxygenation because they basically have blood and fluid in their airways and alveoli. It has to be 2 or more ribs fractured in 2 places. Respiratory distress. They can have crepitus, paradoxical chest wall motion, probably more, about 3 or 4 ribs if you want to see that. Usually could be lateral, or you can see it anterior lateral. Sometimes it's a floating sternum. Flail chest, on the chest X-ray, you get the clinical signs that we just mentioned. You get multiple rib fractures. The main thing is you have to make sure they're ventilating okay, they're oxygenating okay. Lots of times that means pain control. The ventilation is not necessarily from the paradoxical motion, it's from the pain. They don't want to breathe. And oxygenation would be a pulmonary contusion part or for really bad ventilation. And rib plating is recommended for flail chest. It decreases all kinds of things. So rib plating is good. Decrease hospital days, decrease ICU stays, decrease ventilation time. It decreases the need for intubation. So pulmonary contagion, as I said, edema, bleeding airways, you get a ventilation perfusion mismatch. You can evolve acutely where patients need supplementary oxygen or need to be intubated. It could have a chest wall injury, but kids can get pulmonary contusions without chest wall injuries, and adults can too, like with blast injuries can cause severe bilateral pulmonary contusions. I've seen 2 people in Afghanistan dead coming in with blood coming out of their airways from bilateral pulmonary contusions without a mark on them. The other thing included with blast injuries is a cerebral contusion without a mark on you. And so severe acute bilateral contusions, they need ECMO. If they have a head injury, you're not going to get ECMO. So you treat them like with severe ARDS. Rib plating, again, is recommended very much for a patient with a flail chest, probably with multiple rib fractures too. Penetrating trauma, I won't go over the whole thing, but you can see if they're unstable, you put your chest tube in. If they have a massive pneumothorax, it's ongoing, they have to go to the operating room. If you have a positive FAST, you have to go to the operating room. Would be a left thoracotomy if they're unstable. If they're in cardiac arrest, they go to emergency department. If they are stable, then they get worked up with their chest X-ray. If you see a pneumothorax on a chest CT, you can't see it on a plain film, it's an occult pneumothorax. Most of the time, they do not need chest tubes. They might need a chest tube if the patient's going to the operating room or it's going to be on the positive pressure intubation. If you do your FAST, but if you want to make sure if you have an injury near the box, get a formal echo to be sure. And then other adjuncts, if you have a transmedial gunshot wound, it's like a neck thing. You have to do workup, which includes the vessels, the esophagus, and the trachea, and see if they have any injuries with the CAT scan. There's a fusion around the heart with a FAST. These are thoracic incisions. This would be kind of more formal if you have a heart wound that you know exists. This is your left anterior thoracotomy is here. This is a posterior thoracotomy, which would be specifically for a blunt aortic injury. You can't do this on someone who's unstable because can't position them like that. Lots of places will do the left anterior and go right across with a clamshell. Have great access to the heart then. It's kind of hard to fix the heart if you just stick with the left side. And if you see a question on exam, I've seen it many times, and they say you have a proximal subclavian injury on the left, I think actually immediate sternotomy is the way to get there, but they're going to talk about this trapdoor incision, okay? So don't pick the immediate sternotomy. This is wrong. And so tracheobronchial injury, you might see a pneumomediastinum, you might see it on a CT. A lot of these patients have massive air leaks when you put a chest tube in. You tend to put a second chest tube in. Sometimes you can't ventilate the patient very well because the air goes straight out into the chest tube and you can't ventilate the good lung. And the patient could be dying. So you need to do something in the trauma bay. If the injury is to the left bronchus, most of the time, if you just push the endotracheal tube into the right bronchus, you can at least ventilate that lung and keep the patient alive until they go to the operating room. If the injury's on the right, you need to use a bronchoscope. You can diagnose in the trauma bay if you have a bronchial injury and then slide the endotracheal tube in on the good side. They do need to be fixed. If you have a lung laceration, if they're hemorrhaging and you're doing an ED thoracotomy, cross clamp the hilum. I use a big Satinsky clamp myself. You can suture staple, do tracheotomy to suture vessels, staple off the lacerations. You can do an anatomic or non-anatomic resection. Bronchial injuries need to be repaired. They need to be covered so that they don't leak, and which can cause, an air fluid problem. You can use pleural muscle. Traumatic pneumonectomy has a high mortality rate. Just so you know that. And the chest tube, you need to put chest tubes in. This is an atrial injury that you can whip closed. So cardiac injury, if you need to relieve cardiac tamponade. If a patient arrests from cardiac tamponade, they have a much better chance of survival than someone who arrests from hypovolemic shock because their body's perfusion is great right up to the moment they tamponade. Whereas with hypovolemic shock, their body perfusion has been suffering for a long time. So that's the reason why you can save these people. The right ventricle is the most common injury because it's up front. Stab wounds have the highest survivability, obviously, because the whole small 22s I've saved also. Finger control of the wound, if that works, then you can have everyone kind of set things up in the OR around you. Atrial injuries can be partially closed with a clamp because it's soft, the muscle will rip on the ventricle. You can suture it together. You can consider stapling ventricular injuries in the trauma bay with a skin stapler. You can use a Foley balloon if the hole is big and your finger can't do it, and just have to be careful that there's no traction on it, just enough traction. The ventricles have to be repaired with pledgets. Avoid the coronary arteries if you can. You move to the OR once the hemorrhage is controlled, and that could just be with your finger. The cardiac surgeon can decide if they need bypass or not. You should always get a post-op echo because you don't know if there's anything injury to the papillary muscles and things like that. You can see the pledgeted sutures here. So massive air, so bronchial tear with a pulmonary vein injury. Patients can be relatively stable until they're intubated and positive pressure puts air into their heart. And these are the things you have to do. Good luck in trying to save someone who's in full arrest and trying to do all those things. This is the injury that Princess Diana died of. For a transmedial gunshot wound, you get a CT. If the tract, if the vessels look right and the tract is not near the esophagus, then you don't have to do anything. If the tract is near the esophagus, you should do your swallows. The trachea is only part of the mediastinum. If it's near the airway, you can do that. Look with the, I should go back there. Esophageal injuries have to be evaluated quickly. You can't wait. If patient's intubated, say, maybe I'll wait and see the extubating and stuff, because the longer you delay, the more morbidity you have with infection and the difficulty repairing it. If you see a thoracic duct injury, you ligate it. If it sounds post-op, you change your diet. You know that from other things. And then right tracheal injuries can be fixed with right thoracotomy. Esophageal injuries right on the top, left on the bottom. There's a tracheal injury there, esophageal perforation. Most of them are penetrating. You can have some blunt things, so high index of suspicion if you see any mediastinal air. Lots of them are done by an endoscopy. If it's a small amount of air, patient has some pain but seems stable, those might close. And so with people who have endoscopy, so you don't have to rush into the operating room. If it's bad trauma, though, you probably have to do some primary. If you get them early, you do primary repair. I've seen the esophagus replaced if it's later than 24 hours, and they'll do a pull through. So aortic disruptions, if the patient has it, of the survivors, 85% the ligament arteriosum. The same amount happens in the ascending aorta, but those people just don't come. They're dead. So if you're preoperative or treatment for a grade 1 or grade 2 injury, you can see them there. You might just make the systolic blood pressure less than 100, let the heart rate less than 100. They call it anti-impulse therapy. Beta blockers, calcium channel blockers, nitroprusside initially if you need to. The other ones have to be repaired. The way to go is with a stent for everybody. It used to be the young people would get a repair because it would last longer. You don't have to follow it like you have to with a stent. But even for those people, because the degree of spinal ischemia is much, much less for a stent repair than open repair. Non-operative interventions for very old people. People have very head injuries for the low grades, and just have to follow them with CTAs for the lower grades. Sometimes the patient has such massive pulmonary contusions that you can't really operate on them. But now with a stent, you can just use a stent. You have to do anti-impulse theory. I would ask what this is, but obviously it's a diaphragmatic rupture. Any penetrating injury near the diaphragm must be evaluated for a diaphragm injury. What I like to do is if a patient's stable, I watch them for 24 hours, and I'll put a scope on them to see if they have a diaphragm injury. That's for a stab wound. For blunt trauma, sometimes you can't tell. You have to rely on your imaging. It might show up a little bit later. Hopefully, like the x-ray we just showed, it would show up early. You always fix with laparotomy because they 50% have abdominal organ injuries and because of the blow to the abdomen for blunt trauma. If it's found late, you might have to do a thoracotomy. Lots of times you do both on the late one because it's the abdominal contents are just stuck in the chest. And you have to pull them down and you have to push them down, all kinds of stuff. You can get a significant hemorrhage from the chest due to abdominal organ injury. So I've had patients that I've had to make a decision. They're bleeding out of a chest tube, but they have a diaphragm injury, probably the spleen, and that's what it was. So common things are common. You go through the abdomen. If you get food in the chest, like if you put a chest tube in the stomach because you didn't recognize it, or they have a hole, that thoroughly needs to be washed out, or they're guaranteed to get pulmonary empyema. You gotta wash it out. Blunt abdominal trauma, you can see there basically hemodynamic instability. You had to make the diagnosis with your FAST. Probably not a DPA anymore. If it's FAST is positive, they go to the OR. If their FAST is negative, you have to look for other reasons with those 5 other areas or 4 other areas where you could bleed. And then you might keep going down. You might end up in the operating room anyway because you can't find anything else and you're highly suspicious. Always repeat the fast. The fast can be negative and then can be positive. You need to have 500 cc's of blood in your abdomen in order to see it. So your first fast might not see it, and your second fast might see it. Obviously, you get a CAT scan if a patient is fall, standing, things like that. I think I'm gonna have more of that there. So if they have a normal exam, see 5% of the CTs can be positive in stable patients, probably a little bit generous. It depends on how many CTs you do. But if you have a normal exam and good mental status, low mechanism of injury, some people say you should CT everything because you might 8 to 12% missed injuries for mechanism of injury, and you'll see that. But we don't do it for older people who fall and hit their heads, kids that fall on bikes, things like that. Obviously, kids that have no normal abdominal exams, the pediatricians won't let you CAT scan them anyway. So, so you can watch these people, do your ultrasound. If you have those signs there, we have seatbelt signs, you have lower rib fractures, always be suspicious. You need to do a CAT scan. If you have a chest X-ray, is always good because you need chest injury. You can also see free air or diaphragm injury. And then a TPL, those are the numbers there. I don't think you'll see that answer question because they really don't do it anymore. But those are the numbers. I mean, you get a copy of this. If you have penetrating abdominal, is the patient unstable? That's the answer for trauma and everything. The patient's unstable, they go to the OR. Now, we used to say all gunshot wounds go to the OR, but, and I don't know what you're going to see on the test, but if you can CT patients who are stable, if they have tangential wounds, obviously you don't need to operate on them. If they have a wound that goes through the liver and they're stable, just like a blunt trauma liver, you don't necessarily have to operate on them. If the question is equivocal and you're out in the slate, always go pick the operating room for questions that kind of think that you're leaning you that way. For stab wounds, if you have hard signs, you should go to the operating room. You can see them there. You can do a local wound exploration. People, if you go through the anterior fascia, people think that's enough. Nowadays, you can put a scope in there to see if there's any posterior fascia or peritoneal penetration. If you're good with the scope, you can even do an exploration with it. Lots of stab wounds, people, especially in high busy centers, will just watch them for 12 to 24 hours, and if they don't turn bad, you can discharge them. You can get a CAT scan, you can do DPL, which you probably won't do anymore. Laparoscopy, as I just talked about. If you have a flank wound, you want to check the urine for RBCs. You want to basically check the kidneys and the colon. You do a triple contrast CT. It's great. It works great. You have to have that rectal contrast, no matter how resistant they are. Damage control. You stop the bleeding, contamination, resuscitate in the ICU. The triad of death, of course, is acidosis, hypothermia, and coagulopathy. It's what massive transfusion trying to combat. Obviously, you have to stop the bleeding. Stop the bleeding first, along with massive transfusion. Again, we talked about ED thoracotomy, maybe in blunt trauma if the patient loses vital signs in front of you. Rebola, zone 1 is thoracic, zone 3 is below the the renal arteries for pelvis fractures. You have a solid organ injury, you control the hemorrhage. Vascular, you clamp, obviously, and depending on how the condition of the patient, you can either repair it primarily or shunt it. A lot of people did in the war. And if you're not a vascular surgeon, you're not sure about doing a closure and it being good, then leaving a shunt is great. You need to know where your shunts are and how to do it. You stable the bowel injuries, but don't repair because you're coming back for a second look. You can do preperitoneal packing for pelvis injuries. Sometimes you're in there and it bleeding from the back of the pelvis, so you just pack the pelvis in general. And then take the patient IR to control the hemorrhage that way before you go back. You can use IR, obviously, for all the other organs before you go back, especially the liver. Leave abdomen open to avoid compartment syndrome. Sometimes compartment syndrome is good if you have a liver injury and you want to stop the bleeding. Prep for knees, generous incision, remove packing from benign areas first, unless the bleeding is uncontrolled, then go there first. Run the bowel from the esophagus to the rectum, check the lesser sac, don't forget on it, and you have to decide what kind of closure you're doing. Look for that retroperitoneal hematoma. There's the spleen grades there. 1 through 3 are pretty easy. I think the spleen is pretty easy, all that. They're what they look like on the side there. Massive hematoma. We'll go over them all because we're running out of time. And if you have if you have bleeding or active extravasation, then you increase your grade by 1. If they're unstable, you should go to the OR. You can do a splenectomy or splenorrhaphy. Those are the things that you can do. Complications of splenectomy, you can get the pancreatic tail. If you think it's too close to the pancreas, leave it drain. Sometimes people can devascularize the stomach with the short gastrics because your clamp is too long. Just be suspicious if the patient's sick afterwards. Non-operative management, you can up to 2 to 4 units. The rupture rate, the delayed rupture rate, this is like after 48 hours, is about 10% per grade. 4 and 5 need to go get angio Embolized, grade 3 is in between. If you have the pseudoaneurysm, they should be embolized. If you have slow blood loss or large subcapillary hematoma, I also would send them to IR. And then this is the stuff for overwhelming pill-synectic sepsis, which you should know. It's not as bad for patients who lose their spleen for trauma, possibly a little bit more for kids. They need their vaccines up to 2 weeks post-op. A lot of times we'll give them to the patient when they leave because we don't know if they're going to come back. This is just types of ways of explaining the screen. Liver is very similar. If you look at the numbers, so if you need to know the grades, 1 through 3 is 1 to 3 centimeters in blood, so on, 10 to 50% subcapsular hematoma. This is most of below before 4. This is involving 5 segments, or they have a juxtahepatic vena cava injury for 5. This is lethal. And so you can see the things there. Not much more to say about that. You can see nice imaging there. So you only operate if patient's unstable. This is, of course, for lung trauma. It could be for penetrating trauma too, if the liver is the only thing injured. This really works 99% of the time. Then you pack. If you have to operate, you pack. If the packing works and the patient stops bleeding, then you formally pack them with packs, and you might use plastic on the liver. I don't necessarily do that. I just pack them. If the patient's not going to bleed just from pulling the packing off. And then you go to the IR, make sure you take the arteries out before you go back to remove the packs. If packing doesn't work, and you do Pringle maneuver, which is clamping the hepatoduodenal ligament, not with a Kelly, with a vascular clamp or a loop. If that works, then you can clamp, unclamp, and get the arteries. If it doesn't work, you probably have a hepatic vein injury, and you have to go for it. Sometimes if it's a vena cava, you can push the liver on it. You'll read about shunts. I think that's really hard if you've never done it. I think you cross clamp the aorta. If someone's bleeding out, let them catch up, push the liver against the vena cava, let them catch up on top, and then you clamp above and below the vena cava. You might have to go through the diaphragm to get it right before it enters the heart. I think that's the best chance you have. Cross clamp the aorta first. These are just different things in packings, and you can use omentum in lacerations. There's a Pringle maneuver. There's isolation of the liver, complications, liver necrosis. You might have to debride, you might not, depending on the condition of the patient. They can have hemophilia, which is an arteriobiliary fistula, blood from the common bile duct. You see that on the endoscopy, and they need the angioembolization. That's not an operation. And you can get biliary ascites, which you can drain laparoscopically. I've certainly done that. Injuries to the kidney, you can see them there. Basically, grades 4 and 5 involve the hilum of the kidney. These aren't dead. For blunt trauma, it's always non-operative management unless unstable. For penetrating, if you don't have an expanding hematoma, there's a gunshot wound through the kidney, leave it alone. If you think that they're bleeding, if they're urine or something like that, you can leave it drain, or you might want to attack it, but you can leave it alone. You suture the kidney with pledges like the heart. You close the conduction with absorbable sutures, do a partial nephrectomy. Usually if you see a kidney that's devitalized, if they have a kidney on the other side, it doesn't need to be. Most vascular surgeons won't do anything. They can get hypertension in the future. If you have to do nephrectomy, it's good to check the other kidney and make sure it's okay. Then if it's not, then you have to decide which kidney you do nephrectomy on or whatever. Or trying a little bit hard to save it. Those are the different maneuvers. A bladder, a psoas hitch, pulling the bladder up, or flabber. These are for your urologic injuries. If it's very proximal, you have to do a nephrectomy. If the other kidney is okay. Ureter to ureter just isn't very good. If you have a bladder injury, it's always with gross hematuria. Do check it out with a retrograde cystogram. It's usually extraperitoneal. They can just have a Foley for a couple weeks. If it's intraperitoneal, they probably should be fixed. Even those can sometimes be fixed with the Foley. It's the only thing, but most of the time we say, you see it on a test, go and fix it. Urethral injury, these are the signs. Suspect with pubis fractures. I get a retrograde urethrogram before you put the Foley in. And if you have a disruption, do a suprapubic catheter. Latest article from 2023 compared direct repair that they can do endoscopically or suprapubic catheter, still the best, and they to fix it in a delayed fashion. These are duodenal injuries. We'll go over each one of them. Just remember anything in D2 where the ampula is bad. Latest is not to do an operation like this, is to do a direct repair. If there's just no tissue there, you can do a serosal patch. You can actually do a Roux-en-Y. Serosal patch, just putting the serosa right on the duodenum. You can do a Roux-en-Y if there's that much tissue loss that you just can't do a primary repair. But if you do a primary repair, the main thing is to have drains, and probably have a feeding tube. So I think this is probably the way to go if you do a primary repair, but you're worried about it leaking. You want to have a feeding tube in because you want to feed the patient. You want to have it drain the stomach because you can divert, and they won't have an NG tube forever. So those are the pancreas. Mainly, you don't have to do anything with these except drain. If you see it on a CAT scan, don't do anything. If you're in the operating room, you put a drain in. This, you try and do a distal pancreatectomy and drain everything. This is evolving. Some people talk about doing a grade 4. Of course, you're going to lose a lot of pancreas that way. It's a little bit harder. Probably for damage control, just put the drains in. You can decide a little bit later. Obviously, for if an injury does a Whipple itself, damage control would be to stop the hemorrhage, staple off the duodenum, remove all the dead tissue, close the bile duct, and drain. Come back in 48 hours. It'd be a lot easier. The bile duct will be nice and big, and you can finish off your Whipple then. So don't do a Whipple on the first operation. So gastric trauma, mostly penetrating, pretty easy. We'll go over that. Make sure you look for the posterior hole. That's the main thing on this. Small bowel injuries, again, pretty easy. This is the most common organ injured on penetrating trauma. For blunt trauma, you have to have high index of suspicion. If you have thickened bowel, centering the mesentery, obviously abdominal pain. Free air is a hard sign. Free fluid without solid organ injury is not a hard sign, but they might have it. If they're tender, then you need to observe them. You might have to put a scope in there if they're not getting any better. Colon, they actually came out with this is grading also for small bowel injuries, by the way, but I thought I'd put that in there because that came out. And main thing is that even with grade 5s, where you have this really hard, there's still 50-50. People are still transecting and primary repair. So you have to decide. But the patients who are really, really unstable a big segment of colon's going on, and you want to get out of there and not come back, then you should probably do a colostomy. But most of the time, the thing on colons is to fix them, fix the holes or transect, then resect and put them back together. Penetrating for rectal, if it's below the peritoneal reflection, they should always get diverted. Presacral drains plus minus to clean things out down there. And if it's above, you can almost treat it like a colon injury if it's above. But you might consider colostomy depending on how low it is. Transpelvic gunshot wounds, you have to rule out. Vascular injury, you got to rule out. Rectal injury with checking for blood for gross hematuria. You obviously get your CAT scan if you have a vascular injury and see if you have any hints of injuries of those. They need a proctoscope. Definitely need a check the urine. Zone 1, you're supposed to explore. Not on blunt trauma, though. If you've seen zone 1 on blunt trauma and the patient's stable, just keep watching them. That's if you don't operate on them. If you operate on them, you have to explore. Zone 2, again, we've mentioned that before. Those are the kidneys. If they're not expanding, you don't have to explore them. Zone 3, you try never to explore, even in the operating room. You might pack them if they have an obvious active hemorrhage, like the iliac arteries and veins. Sure, you got to explore them. But if it's not really pushing up, you try and stay because it might be related to a pelvis fracture. Penetrating trauma, you should explore zone 3. For vascular injuries, damage control. These are different things that you can do. Mannix maneuver, medial rotation of everything, IVC, Cattell maneuver, which is everything but the kidney, retrohepatic vena cava, you pack, you pray, and then you isolate as we described before. Infrarenal aorta, you can see them all there. You reflect your mesenteria superiorly, put your clamps on. And I think it's probably you get to the left common iliac vein to transecting the right common iliac artery because it crosses over. And the stable patients with injury discovered on CT can be considered for endovascular repair. So again, vascular injuries, aorta, PTFE likely. They talk about spiral grafts. Anyway, if you have a colon injury, you might have to do an X-ray. You might look for a question that says do a XFEM and not repair the aorta with a PTFE graft. Lots of people probably try and get away with it, to tell you the truth, but they might, if you see an XFEM in there, you might choose that. If it's subhepatic IVC, you can ligate if the patient's dying. Otherwise, you repair the back wall of an IVC through the anterior wall. Celiac access, you can ligate. Renal vessels, you can ligate if the other kidney's fine. Iliac artery repair, try to. You might have to ligate into a fem-fem, especially if there's contamination. Iliac vein, you try and repair or ligate. SMA, you might have to ligate or exsanguinating, but then you have to do a bypass. SMV, you might have to ligate and then pray, possible bypass. Hepatic artery, you can ligate. Portal vein, you should repair. If you have to, you might have to ligate. And then the saphenous vein, use that as opposed to PFD when possible. Pelvis fractures, if they're unstable and they have a positive FAST, they need to go to the operating room because they obviously could have some other injury. And then you do preperitoneal packing while you're there. They also can get an external fix while you're there. If they're hemodynamically stable, then go for a CT scan, look for the injury. If they have a blush, they should go to angio. Some places go primarily for preperitoneal packing. I think there's places that don't have angio suite available 24 hours a day. And then you can always pack, and you should go to angio after the operating room. These are the type of pelvis fractures. Lateral compression, AP, is the ones you remember most with the pubis fracture. This is 2 centimeters, 4 centimeters, more than 4 centimeters, and a vertical shear is ripped off. This is the one that bleeds the most, the APC3, the open book. You fix it by closing the book by using a binder. You use a binder on everything. The orthopedic surgeons say, well, you don't need a binder on a lateral compression, but if the patient is bleeding and have a pelvis fracture, you can't tell. Just put a binder on it and help keep things moving anyway. Obviously, if you have Erbo, you can do that, but a lot of places don't necessarily have that. Otherwise, you use a binder, you go to the operating room, possibly a preperitoneal factor if they're unstable, X-fix, and then we talked about going to vascular trauma. You want some hard signs, penetrating trauma, you should operate. If it's blunt trauma and you don't know exactly what the injury is, then do a CTA. Soft signs, probably everyone would probably do a CTA. They talk about not doing anything for proximity, and if they see a question like that, then you probably absolutely no soft signs at all, no signs at all, and it's just proximity. Then you don't need to do anything. In practicality, most people probably do a CTA. There's just an algorithm. I think you get a copy of this. Fractures, just remember pulseless, you reduce them and check again. If you reduce someone who's not pulseless, check for pulses, make sure you didn't hurt them. You have to document, it's very important to document your neurologic exam because you don't want to get in trouble for having done something if they already had the problem. If you reduce femur fractures, they'll have less blood loss. They try and fix lumbar fractures within 24 hours. That's plus minus decreased fat embolism. But I think they might still say that on the test. Hit those locations are orthopedic emergencies because they can lose their femoral head, so they have to be reduced. Open fractures need to be washed out in 8 hours. Compartment syndrome. You want to stabilize. Ideally, you want to stabilize orthopedic injuries quickly before vascular repair. And then the NSAID is given for open fractures. You might need gentamicin if you have really dirty wounds or something has arterial loss or whatever. You can read the Costello classification here. And then also there's also mangled extremity score. Compartment syndrome, the 5 Ps. If you have one of the Ps, it might be enough. You check compartment pressures. If they're above 30 or if there are 20 difference from the diastolic pressure, then it's positive. You do fasciotomy. You do 4-compartment fasciotomy. None of this 2-compartment stuff. Incisions, I do, but incisions at both sides of the leg. Abdominal compartment syndrome is labeled there. You have hypertension if you have blood pressure over 12. I think that's kind of soft. I'd say over 20. The syndrome would be over 20, but you also have to be symptomatic. Oliguria, increased respiratory pressures, probably hypoxia, and hypotension. Then they need a laparotomy. Pregnant women are hypovolemic. They tolerate shock a little bit more. Fetal distress can be an early sign of shock, so it's important to listen to the baby's heart rate. After you do your ABCs. To save the baby, you have to save the mother. You can check a Becky test. Placenta abruption is the most common injury to fetus. That's why they need to be checked. If they have a viable pregnancy, be checked for 6 hours. This should be a part of the trauma program. They need to be checked for 6 hours for contraction, and they need an ultrasound. If you can get to if a mother is absolutely dead, and you can get to the fetus within 5 to 10 minutes, the fetus can survive. Don't let if the mother's not dead, don't let them start cutting the fetus out on a woman that's not dead. There's the burns there. I think you kind of know, except for a second degree. Resuscitation formulas are changing. I think this is all good stuff to know. Rule of 9, physiology, early excision, and putting in your grafts, the cultured skin. Nutrition is very important. We talked about intubating early for inhalation injuries, checking with a bronch. Some of the stuff you need to know, like chemical burns, you wash off hydrofluoric acid, electric burns. They might be deep burns to the muscle. You have to check myoglobin. You might have to check a muscle scan to see if they have it. Remember, they might need a fasciotomy besides an escharotomy. It's full thickness through the skin of digits and toes. You might have to do it on the chest too, if they're not ventilating correctly. Hypothermia, I think the main thing is rapid rewarming. For hypothermia, rewarming, as you see there, a patient can't be declared dead unless they're 35 degrees, which, give or take, because you might be doing it for a while. If you can't get a patient warm because they're dead, then they're dead. I mean, we've lasted like you just can't get their temperature no matter what we do because they're dead. And so that's just the way it is. And so you rapid rewarming for frostbite, and don't forget VTE prophylaxis. You can see the things there. You should do it within 24 hours for trauma patients with had lower extremity multiple rib fractures, torso injuries, spinal cord injuries. With brains, good study last year. 48 hours is pretty safe. It's okay to use heparin, or if you want to use heparin, you feel safer with it, it's okay. But Lovenox is the choice for trauma patients. The West guidelines, actually, if someone's less than 65, use 40 twice a day. At least use them for BMIs over 30. And you use SEDs at all times when you can't use chemical prophylaxis, and that's it. I don't know if I'm overboard, but I figured that you got a lot of information there, and I'm last, so if you have any questions.
Thank you, Dr. Doyle. I had sent out the slides that you gave me to the group already.
I sent them to where do I send them to? I sent them to
You sent to me, MTN. Yes.
yeah.
I sent it to the chat already so they can download it.
Yeah, do you have them?
Yes, I think they do have them.
Okay, great, because there's I think there's a lot of good information on there, and it's pretty
Yes.
complete, so. Okay. All right, well, I don't have any questions, and good luck on your ABSITEs. If you want to contact me, no problems. Any other questions you have, or pearls or anything like that?
Thank you so much for your time, Dr. Doyle.
Take care now. Bye-bye.
Bye-bye. So I just want to conclude our CTSS review and a few shout outs to a few resident committee that I have. Jeremy Fredling from UK.